With these introductory words, I now request Dr. Padmaja Kumari Rani to start the workshop. She will be actually presenting a few talks, and then Dr. Sanjay Agarwal, Honorary Secretary of RSSDI, will also give us the perspective of diabetes, what we should know about diabetes, not just in relation to retinopathy, but in general also. And then we will have a few talks by Dr. Rajiv Raman on referral guidelines and management. And then we will end with interactive quiz and post-assessment feedback. So over to you, Padmaja.
Good morning, everybody. I think this is a unique moment and a great beginning in my career to see beginning of a diabetologist and ophthalmologist working together. And this is something happening due to unique association that is happening between RSSDI, AOS, and VRSA workshop. So many of you might have received this pre-assessment form. I'm just keeping it for a moment for you to again capture. And in this workshop, the first talk will be touching upon epidemiology, pathogenesis, and classification of diabetic retinopathy. So when we look at world's most populated countries, in Asian countries, the China is actually having the highest number of people of diabetes, followed by India. And when we look at diabetes in Dr. Sabu's address, it is not just eye alone, but it can cause multi-system disease. So, but eye can act as a window, and that's how it is an important first step. How a diabetic retinopathy screening can help to even detect the other micro and macrovascular complications. So when we look at globally, there are 415 million people with diabetes, and 50% of them are living in China, India, and USA. So when we look at epidemiology of diabetic retinopathy, Asian scenario, so various prevalence studies, they found that in 100 people, when we screen for diabetic retinopathy, 20 to 40% can have some form of diabetic retinopathy. So why this Asian epidemic versus global scenario? So we do have configuration of thin fat Indian, so where we have increased visceral fat and waist circumference, which in turn can reduce the insulin sensitivity and beta cell function, and rapid economic growth and lifestyle changes. We know that the TVs in front of us are becoming bigger and bigger, and the individuals are thinner and thinner, and the individuals who are sitting in front are becoming obese because of sedentary lifestyle changes. And there is also phenomena of lower birth weight babies, and there is a catch up growth and insulin resulting in insulin resistance, and then again having a risk for type 2 diabetes. And similarly, migrant Indians, wherever we are in whichever countries, because of the lifestyle changes and again the genetic predisposition, we are again having a high risk of type 2 diabetes. Then the most important why diabetic retinopathy can cause blindness is again the most important reason is the awareness. So here we can have a 32-year-old physician who came actually with an advanced diabetic retinopathy due to type 2 diabetes. And this can be across, it doesn't have any socioeconomic barriers in terms of awareness. And we see both lower and as upper socioeconomic status. And one third doesn't even know that they have even have a diabetes. But the good news is the blindness due to diabetes is preventable. And when we look at diabetic retinopathy, when we say diabetic retinopathy in individual with diabetes, when we screen for 100 people with diabetes for eye problems, 60% of them will actually have refractive errors, and cataract 40%, and glaucoma, optic nerve related problems in 10%, and diabetic retinopathy 20%. And most of them also will have retinal vascular occlusion in around 10%. And sometimes the individuals with diabetes can have painless visual loss, which we call it as ischemic optic neuropathy. And sometimes the patient with people with diabetes can just walk in your clinic saying that I have double vision, and which is again due to diabetes affecting the blood supply of the extraocular muscles, resulting in now either third nerve palsy or sixth nerve palsy, and they can present with double vision. So this is the whole spectrum. We call it as diabetic eye disease, and all can cause severe visual loss or even blindness. So when we look at retina, eye is like a camera. Retina is the most important sensitive layer. And when we say diabetic retinopathy workshop, it's not just only diabetic retinopathy workshop, where signs and symptoms. We need to look at when you see a normal retina. So we need to look at the optic disc, which is actually a healthy optic disc will be pink with because of the neuroretinal pink in color. Margins will be clear, a pink disc, and also along with the retina. And the central part, which we call as the macula, which is the posterior pole, which is and the foveal center, which is responsible for the sight sense, the near reading and writing visual acuity. So a normal retina, the transparency of the retina is what is very important, and this picture one should keep in mind. And when we say the patients, people with diabetes, we always tell them that they should go for a dilated eye examination. So we dilate the people, and these kind of videos having in the in awareness material will help them to understand why they need to have a dilated examination. So Dr. Sabu was mentioning what is the most cost-effective screening is a simple fundus photograph, either dilated or with a non-mediatic fundus photography at the clinic. And this is a normal retina. And when we look at a patient with diabetes, when you do the same dilated eye examination, what you see is a diabetic retinopathy affection changes, which will be involving, and can be when it is involving the center, we say the sight threatening diabetic retinopathy. So let us look at pathogenesis of diabetic retinopathy. I would summarize diabetic retinopathy pathogenesis in a simple terminology, what I would describe as red dots, yellow lesions, and flowers. So when we look at pathogenesis, the diabetic retinopathy, initially, because of the high glucose levels, there is a basement membrane thickening and blood vessel supply less, and there is an ischemic stage, initial stage. So diabetic retinopathy is the microvascular complication of diabetes. So what we see initially is a red dots. Is why it happens is because the normal retina has a 10 layers. So the transparency of the retina is the extension of the brain, and which is a transparent layer. So to have a clear vision, the film should be clear. There should not be any swelling. So we have two policemen which will actually keep the retina transparent. They are called inner blood retinal barrier and outer blood retinal barrier. Inner blood retinal barrier is nothing but all the retinal blood vessels. In a normal retina, you have a cells called pericytes, and these keep actually the retina, the retinal layer intact, the retinal endothelium intact, so that the no leakage occurs. But in a diabetic retina, the first sign that occurs is the pericytes are lost. So it means these pericytes, the inner policeman is not working, and that is when these blood vessels, they form like an outpouching. There's a capillaries, and that what is that outpouching that you see on the fundus, the first red dot or the deep red dot, we call microaneurysm. So the first pathological sign is the pericyte loss, and the first clinical sign that you see on a fundus photograph is the red dot. So this is the earliest stage of diabetic retinopathy. And then comes as the diabetic retinopathy, as the ischemia is increasing, the stages. So what will happen is the outer policeman, we say the retinal pigment epithelium. So the retinal pigment epithelium junctions, they actually become tight, and they actually they are like a scavenger, and they will not allow anything to leak outside the retina, so that the retina remains transparent. But when the RP junctions are not functioning because of the diabetes, so again the proteins, the lipids, which are in the blood circulation, they enter the retina, and that is how you start seeing the yellow spots. The yellow spots that we see due to diabetic retinopathy are two in number. One is we call cotton wool spot, which will appear as if it is stuck on the surface of the retina, first layer. And there are hard exudates, which are nothing but the lipid and protein deposits which get accumulated. So first sign is the pericyte loss and the inner policeman not working, and that is how red dots will appear. When outer blood retinal barrier RP function is not happening, and that is when you start seeing the yellow spot like cotton wool spots and hard exudates appearing. And when these in these stages, the most important vision threatening retinopathy occur is in the mild or moderate or in a severe, is the because of the leakage, there's a capillary leakage, and there can be a thickening of the macula. That is what we call macular edema. And as the ischemia is progressing, just imagine retina and the eye like a garden. So there is a factor called angiogenesis factor, which we call vascular endothelial growth factor, and which gets released, and that results in started of what I said about flowers. So that is what new vessels. So these new vessels are not as strong as the original blood vessels, and that is when you actually develop the patient, even if has a valsalva retinopathy or any increased exercise, they can even develop a floaters and then causes the vitreous hemorrhage. And as the neovascular, these new vessels increase started, and they actually, the as the blood sugar, the vitreous is also has a rich in glucose, and it is and it's like acts like a manure, and all these new vessels can actually grow like a big trees. And then when this kind of big flowers or new vessels, when they start forming, and that actually this vitreous can kind of contracts, and one you can have a tractional induced retinal detachment, or because the retinal layer itself become thin and the new vessels start proliferating and contracting, and one can even develop a breaks and can have a combined retinal detachment. So that's how a normal retina, initially it may just start as a microaneurysms and hard exudates, but with the growth of these flowers and the proliferative diabetic retinopathy, where you can have a even a tractional vitreous hemorrhage, tractional induced advanced retinopathy like a tractional induced retinal detachment. So this is in nutshell about pathogenesis of diabetic retinopathy. Let us look at classification of diabetic retinopathy. So the important classification of diabetic retinopathy that we follow, which is called International Clinical Diabetic Retinopathy Disease Severity Scale. This classification has two components. One is a diabetic retinopathy disease severity, and another is diabetic macular edema severity scale. So this classification has been introduced basically in most with the important objective of that both physician as well as an ophthalmologist can follow this classification based on even on a one single fundus photograph. So the single fundus photograph, when I say, it could be around 45 degrees fundus photograph, whether it is a physician clinic or an ophthalmologist can follow this classification. So this classification says mild NPDR, mild non-proliferative, as we discussed already, a single red dot also qualifies as a microaneurysms, and this is the first sign of diabetic retinopathy, which we call it as a mild NPDR, and which is due to loss of pericytes. And when we say red spots, red dots, so the other red dots that can occur in fundus are hemorrhages. So how you can differentiate microaneurysm from hemorrhage? Microaneurysms are usually will be smaller, and many times because of the earliest stage, the microaneurysms also starts can leaking, and they can have surrounding small yellow spots like hard exudates. So that's how one can actually differentiate between microaneurysm and hemorrhage. Hemorrhage, depending on the layer in which the hemorrhage is there. For example, a hemorrhage which is there on the retinal surface will be more like a flame shaped, and deeper layer can be dot and blot, and the margins will be much more, hemorrhage will be little larger than the microaneurysm, and the margins can be irregular. Second stage is moderate NPDR, or moderate non-proliferative diabetic retinopathy. Here, as we just discussed, apart from the red spot, when you start seeing cotton wool spots and hard exudates, and that is when we call it as a moderate NPDR. And when you see these both red spots and yellow spots occurring at least in two quadrants, then we classify it as a moderate NPDR. So when we look at, for example, here I was discussing about different red spots. So these are the microaneurysms. And as I said, that when the retinal hemorrhages are at the nerve fiber layer, that means at the stage of the, that the first layer that you see on a fundus photograph, that is when we call it as a flame-shaped hemorrhages. But the two important yellow spots here we discuss is cotton wool spots. They appear as if they are stuck on the surface of the retina. They are the most superficial, whereas hard exudate will be appearing in the middle layers of the retina, and where then this is called as a moderate NPDR. The other yellow spot that you can see in fundus, which call it as a drusen, which can be at the more deeper level, and that is more related to age-related macular degeneration. But the important sign, yellow spots that are concerned with diabetic retinopathy are cotton wool spots and hard exudate. Third stage is severe NPDR. Here, remember 4-2-1 rule. What is 4-2-1 rule? For example, when you have given a fundus photograph, when you have more than 20 intraretinal hemorrhages in all 4 quadrants, and then venous changes at least in 2 quadrants, and the third structure we call as a IRMA. IRMA is nothing but intraretinal microvascular anomaly. This is something like a pre-flower stage. So because the proliferative diabetic retinopathy, as I said, flowers are new vessels. So this is something like an attempt at severity, which is severe NPDR can go into PDR. However, for all practical purposes, when you see a fundus photo, and if you are seeing hemorrhages in all 4 quadrants, you should err on the side of severe NPDR. Along with that, you can see cotton wool spots depending on the level of the ischemia and also the hard exudates. And when you do an angiogram, IRMA is on fundus photograph, sometimes it may be difficult to differentiate, but when you do an angiogram, the new vessels, because they lack completely the retinal endothelial junctions, they leak profusely, whereas IRMA may not leak so profusely. So IRMA is one differentiating feature, how we can say severe NPDR. But to practical purposes, when it's given a fundus photo, if you see hemorrhages in all 4 quadrants, you should classify that as a severe NPDR. Then fourth stage is proliferative diabetic retinopathy. So when we say sight-threatening retinopathy, diabetic retinopathy, we say from severe NPDR, we classify it as a vision-threatening retinopathy or sight-threatening retinopathy. So in proliferative diabetic retinopathy, the important factor, the vascular endothelial growth factor, plays a role. And here you can see those fibrovascular proliferation. That is nothing but the vitreous scaffold. I just said that you should imagine the eye like a garden. So the vitreous scaffold and all these new blood vessels, they start proliferating on this scaffold of the vitreous. So that's how you see these new vessels. So whenever you have a small hemorrhage kind of thing, whether it is a new vessels or anything, if you see a glistening fibrovascular tissue, then you know that that could be a new vessels. And the new vessels will not be, will be like a fibrillary tangulary mesh of blood vessels, and they will, and of course with increased ischemic, they can be more stronger caliber also, but usually they will not be like a regular blood vessel. And they can have a vitreous hemorrhage in the form of just behind the highlight, and we have subhyaloid hemorrhage, which is like a boat shape, or it can be a vitreous hemorrhage. However, if a 40-year-old or any diabetic patient with a diabetes, if they come with a pre-retinal hemorrhage like this, so you should definitely consider that it could be a proliferative diabetic retinopathy with a new vessel behind, which could be a simple Valsalva retinopathy, and should rule out always diabetic retinopathy. And as I said, advanced with high risk characteristics. When we say PDR with high risk characteristics, this neovascularization, which is more than everything in retina, we actually try to measure along with the disc diameters. If it is more than 1/3 disc diameter and big fibrovascular proliferation, or any NVD with pre-retinal or vitreous hemorrhage, or NV which is more than half disc diameter, then these are all called it as a high risk characteristics. So any proliferative diabetic retinopathy fundus photo, if you have a pre-retinal or vitreous hemorrhage, that classifies as a high risk characteristics. And here you can see a big growth of new vessel proliferation, which you can see that then behind retina, and it can cause even tractional detachment. And if it is significant, it can even cause a combined retinal detachment. And the next important vision-threatening retinopathy is diabetic macular edema. So when we say sight-threatening retinopathy, one is severe NPDR and PDR. And the diabetic macular edema is again the sight-threatening diabetic retinopathy. So when we say diabetic macular edema, so one classification we do follow is in the clinic by an ophthalmologist is a clinically significant macular edema, where we say whenever there is a hard exudates or zone of retinal thickening which is involving the foveal center, and retinal thickening is common, and this is, we call it as clinical because it is based on your slit lamp biomicroscopy or using a 78D lens. However, international clinical diabetic macular disease severity scale, this classification is just based on the fundus photograph, which can be followed by both physician as well as an ophthalmologist. What does this say? So whenever according to ICDRS classification, diabetic macular edema is classified as a mild, moderate and severe. What is mild? When you have hard exudates or yellow dots which are away from the foveal center, which we call it as a mild DME. And moderate DME, when you have hard exudates, and many a times when you have these hard exudates can in the form of sarcinate, like a circulus, and you can see many a times there can be a microneurysms which are there in the center of this sarcinate. But what is the definition is, when these hard exudates are approaching the foveal center, we classify it as a moderate DME. And when hard exudates are involving the foveal center, we call it as a severe DME. So when you say vision threatening diabetic macular edema, from moderate and severe DME, both will come under as a vision threatening diabetic retinopathy. So when we said that in 100 people with diabetes, you can have 20% have any form of diabetic retinopathy. The vision threatening retinopathy can be 10%, and in the 10%, 8% can be actually diabetic macular edema, which could be moderate or severe DME. And this is also a reason why a patient can say that I am having blurred vision when they walk in either in physician clinic or an ophthalmologist clinic. So to capture, just to revise, a normal fundus will not have any, it is the retina will be the transparent membrane, and the hue of the retina is mainly due to the choroid which is beneath. So depending on the racial region, it could be tessellated, or it could be a grayish, orangish hue. The color of the choroid is what we'll see through. And this retinal transparency is maintained by the two policemen. One is the pericytes in the inner retina. If they are lost, the first clinical sign that you see is a microneurysms that we call mild NPDR. And when you have outer policemen, that is red RP junctions are not functioning actively, then you can see the along with red spots in more than two quadrants, you can see either hard exudates or a cotton wool spots, that is moderate NPDR. And in a severe NPDR, 4-2-1 rule, where you have all four quadrants hemorrhages, and could be cotton wool spots, which you can see is like a stuck on the surface of retina or a hard exudate, then you say it is a severe NPDR. And IRMA can be an angiography diagnosis called intraretinal microvascular anomaly. This is like a pre-flower stage in severe NPDR. And the proliferative diabetic retinopathy can be like a vitreous hemorrhage. This is a high risk characteristics, any PDR with NVD. And you can see the new vessels or the flowers or new vessels will be very, very thin caliber. And you can also see the venous beading changes seen very clearly. So these are all changes indicates a proliferative diabetic retinopathy. And they can progress to either tractional or advanced PDR with combined retinal detachment. So this is my first talk.